Let's delve into the dermatology section of the musculoskeletal chapter. We'll start with a quick introduction to the anatomy and physiology of the skin, and then jump into the high-yield skin lesions and rashes that will get you some of those quick points for spot recognition. To begin, we have the skin. It's the largest organ in the human body. Do you remember the 5 layers? On the top, there's the stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and the stratum basalis. You can remember this fact with the mnemonic Californians like girls in string bikinis. Also note that the stratum lucidum is only present in the thick skin of the palms and the soles. So how are you going to remember this? Remember that L in lucidum is the only letter that is also in both words palm and sole. This diagram also covers a fairly important set of topics. The structures we're going to discuss provide the integrity of the epithelium and allow cells to have specific functions. Here's the apical side of the cell is up here, and the basolateral side is down here. The first structures that we're going to discuss are the different junctions that are key to forming the body's outermost layer. These are the tight junctions, or zona occludens, and they're found apically along rows of epithelial cells. They prevent diffusion across the paracellular space, which is right between the cells. And they prevent large molecules and even individual ions from diffusion. They're made up of 2 molecules, claudins and occludens. And ultimately, they form a zipper around the cells. Just remember that the tight junctions bind so tightly that they don't allow most substances to pass through. The next structure is the adherence junction, or the intermediate junction. This surrounds the perimeter just below the tight junctions. The functional proteins that form these intermediate junctions are cadherins. Cadherins attach to the intracellular actin molecules, which normally function in the cell's own cytological skeleton. What is an important ion to cadherin function? They rely on calcium, and actually it's where they get their name from. The phrase is calcium-dependent adhering protein. So if you can't remember what ion is important in their function, just remember, it's all in the name. Next, we have the macula adherens, which are also more commonly known as desmosomes or spot junctions. How are these connections different? They are literally small, discrete sites of attachment, a lot like a drop of glue. They utilize the same proteins, cadherins, but rather than attaching to intracellular actin like intermediate junctions, they attach to intracellular intermediate filaments. And yes, this is kind of confusing and even a little bit backwards. But why do we care about desmosomes? Because they are key to the pathology in pemphigus vulgaris, which we'll do a bit more in-depth review in the derm section. Just briefly though, patients have autoantibodies to these spot junctions, most often visible at the level of the skin. So, if you think about it, if all the epithelial cells lose their spot junctions, they would lose their ability to hold on to one another. And then what's going to happen? Separation. This happens in enough areas throughout your body. It would form these huge blisters, which is the characteristic presentation of pemphigus vulgaris. A very similar structure to the desmosome is the hemidesmosome, which you see right down here at the basolateral surface. It's sometimes called a hemidesmosome because it literally functions like just a half of a desmosome. It does not connect 2 cells to one another, but rather one cell to the basement membrane at the basal portion of the epithelial cell. Similar to pemphigus vulgaris, patients that develop autoantibodies to these hemidesmosomes will also develop a blistering skin disease, but it's named bullous pemphigoid, which is probably the setting where you're most likely to see these structures appear on the test. For step 1, you'll need to pair these in your mind: pemphigus vulgaris and desmosomes, and bullous pemphigoid with hemidesmosomes. Additional structures that are used to maintain the integrity of the basement membrane are integrins. They function by binding to laminin in the basement membrane. A final structure on epithelial cells is the gap junction. These junctions allow adjacent cells to communicate for electrical and metabolic functions. This provides an efficient and effective way for one cell to communicate to another cell, as you can see right here. Gap junctions are found in many organ systems. For example, some muscle cells, specifically cardiac muscle cells, will spread electrical signals using gap junctions. So some neurons can synapse at a single site and still have that message passed down to many, many cells beyond it through these gap junctions. It saves a neuron from having to pass the message individually to every single cell. It also enables coordinated contraction of the heart from the bottom to the top so that the blood is pumped out, with the signaling originating all in the SA node, as outlined in the cardiovascular chapter. Pretty efficient, right? Okay, let's have a flash quiz. What layer of skin is found only in the palms and the soles? The stratum lucidum. Want a little flash quiz bonus? Which is the stratus lucidum layer in this picture? It's right here in the pink. This section is a crucial one for you to understand as you transition into your wards experience, and also as you try to learn the next couple pages of first aid. This guide attempts to explain the difference between seemingly similar dermatologic terms. Some examples have been provided here to help you out. Let's start by talking about macules, patches, papules, and plaques. What is the key differentiator for the terms? It's the size. A macule is a flat discoloration of the skin that's less than 1 centimeter in diameter. However, if this discoloration were greater than 1 centimeter, it would be called a patch. Similarly, if this skin lesion were less than 1 centimeter, but now it was elevated, it would be called a papule. And if it were greater than 1 centimeter and it was elevated, it would be called a plaque. A classic example of a papule is a small pimple, like you may find in typical acne. However, plaques are the more extensive skin lesions you'll see in a patient with psoriasis. If the plaque has a flaky top layer, then you would call this feature scale. It's the shedding of the stratum corneum. Let's look at vesicles and bullous. What's the most important distinguishing feature here? The size. A vesicle is classically just a smaller, fluid-filled blister, like you would see in chickenpox. If it were bigger, it'd be called a bulla. If a blister is filled with pus, then it's called a pustule. If any of these were to pop and then dry over, it would form what's called a crust, a common finding described in impetigo, which we'll discuss later. A wheal, on the other hand, is a vesicle that appears transiently. What is a common cause of a wheal? Usually a hypersensitivity reaction, like hives. Let's have a flash quiz. How would you describe this lesion? It's a patch. When we look at microscopic terms, we'll be describing things related to the architecture of the skin when you look at it under a microscope. Do you recall the 5 layers of the skin? The stratum corneum, lucidum, granulosum, spinosum, and basalis. We'll see now how different pathologies will have classic findings on histology that affect this diagram of the skin. In diseases like psoriasis, a common finding is a thickening of the stratum corneum, the topmost layer, which is called hyperkeratosis. What if hyperkeratosis occurs in the stratum corneum with nuclei retention? Then it would be called parakeratosis. Do you recall what happens in pemphigus vulgaris? Antibodies cause separation of epidermal cells. This blistering is called acantholysis. Acanthosis, which sounds similar, is a problem of the spinosum layer, causing hyperplasia and discoloration. The next set of diseases we'll touch on are the diseases of pigmentation. There are 3 of them that we'll discuss here, but there are in fact many more. Some of these diseases, like albinism, are general terms that describe a spectrum of diseases. One form of albinism is caused by decreased function of tyrosinase, a critical enzyme for the formation of melanin. If you look at their skin histologically, would you expect to see changes in the number of melanocytes, or average melanin production per melanocyte? So, You should expect to see the same number of melanocytes, but each melanocyte produces much less melanin. Defective tyrosine transport can also result in a similar presentation. A different form of albinism occurs as a result of poor migration of neural crest cells into the skin. In this form, the melanocytes, a neural crest derivative, never actually make it to the skin, and therefore, a decreased number of melanocytes is the actual cause of the disease. What's another disease that results from the migration failure of neural crest cells? That's right, Hirschsprung's disease. A different disease entirely is called vitiligo. Here, the problem is more focal and usually not as generalized as it is in albinism. The main reason for the disease is because of a decreased number of melanocytes, usually as an acquired phenomenon, which means the neural crest derivatives made it to the skin and were working fine until some idiopathic insult caused them to be destroyed. A final skin pigmentation disorder is the one seen in pregnancy, which is called melasma, or the mask of pregnancy. What else might cause melasma? We often see this in patients who are using OCPs, which clearly indicates the role of hormones in this hyperpigmentation. Which skin layer does acanthosis affect? The spinosum.